Hello, everyone. Happy Tuesday. Thank you so much for joining us. So I'm Sosan. I'm a medical graduate from Jordan, and I'm so happy to be facilitating today's session. We have three astonishing Academy members, Masa, Julia, and Bayan, who will be sharing their insights and some highlights of cases that were presented in the past month. And without further ado, we're going to start with Masa. Can you please introduce yourself and share your screen?
Hey everyone, I'm Masa. I'm an IMG from the United Arab Emirates and a proud member of Clinical Problem Solvers. Thank you, Sosan, for the intro. I'm gonna share my screen. One moment.
Just before Masa starts, sorry, this is an interactive session, so feel free to leave your thoughts and your answers for the questions that are being asked by the presenters as well. And yeah, go ahead, Masa.
So I am going to be recapping a case that was presented by WashU on the 16th of November. And it was co-discussed by my friends Umayma and Sosand and our one and only Dr. Rabi. So this was a case of a 76-year-old male who presented with 3 days of severe lower abdominal pain associated with difficulty urinating and passing stool. He was confused and disoriented. On physical exam, a fluid wave was seen and ascites was confirmed on CT abdomen. On paracentesis, there was a white blood count of 1,100, a SAG of 3, and a serum creatinine of 4.24, and an ascites creatinine of 20.7. So this patient came in confused. What initial step or test would you get? Let me know what you guys think in the chat. What test would you get for a patient who is confused? Yep, so we would get a point of care glucose. And this is an elderly male with sudden onset of lower abdominal pain. So when you think of such a patient, what initial test would you get? What would you want to rule out? Okay, so so we would get a bladder scan. So this is an elderly male with sudden onset of lower abdominal pain. So we need to rule out urinary retention. So we would get a post-void residual. However, if we can't get that, we would get a bladder ultrasound. Now, this patient came in with severe abdominal pain. So we have to rule out acute abdomen using our mnemonic VIPO. V for vascular, I for inflammatory, P for perforation, and O for obstruction. However, acute abdomen usually presents with diffuse abdominal pain, and here our patient came with focal lower abdominal pain. So when we have a patient that presents with localized abdominal pain, we divide the abdomen into 9 quadrants, and here our patient presented with lower abdominal pain, so we're gonna focus on the lower abdomen. And here we think of things like appendicitis, colitis, diverticulitis, cystitis, or urinary retention. And in females, we think of ovarian torsion or endometriosis. And you can find this schema on the CPS website. So this patient had ascites on CT. So what do you think are the 3 most common causes of ascites in the US? Yep, cirrhosis, malignancy, and heart failure, exactly. So cirrhosis is due to increased portal hypertension, malignancy because of malignant peritoneal involvement or secondary metastasis, and CHF due to increased hydrostatic pressure. So when we have ascites, we divide it into exudate and transidate. Exudative ascites is due to elevated capillary permeability, and this can be because of inflammation. So we think of things like TB, cancer, serositis, pancreatitis, and transidative ascites occurs due to increased capillary hydrostatic pressure. So fluid is being pushed out, and this is like CHF, or decreased capillary oncotic pressure. So fluid is being pulled in. So this is due to decreased protein intake, decreased protein synthesis, or increased protein loss. And to differentiate between exudate and transidate, we get SAG. SAG is serum albumin minus ascites albumin. So in exudate, we have capillary permeability because of inflammation. So the water that goes out takes albumin out with it because the capillary wall is permeable. So albumin and water go out, and so the serum albumin decreases and the ascites albumin increases. And so the difference between the two is less. So SAG is less than 1.1 in exudate. However, in transitate, the capillary wall is intact. So only water comes out where albumin stays in the capillary. So serum albumin becomes concentrated and water goes into the peritoneum. So acidic albumin becomes diluted and the difference increases. So in transitate, SAG is elevated. It's more than 1.1. We can also divide ascites into portal hypertension ascites and non-portal hypertension ascites. So in portal hypertension ascites, we'll have an elevated SAG, so that's transidative. And in non-portal hypertension ascites, we have a low SAG, so that is exudative because of inflammation. So things like infection, autoimmune, cancer, or other inflammatory processes. However, we can have non-portal hypertension ascites with an elevated SAG. And these exceptions include peritoneal dialysis, urine, and chyle. And in our patient, he has ascites, an elevated SAG, but no evidence of cirrhosis or portal hypertension, and his serum creatinine is significantly elevated. So that means he has an AKI in the context of acute ascites. And in this case, we think that there is a fluid in the abdomen that is compromising renal perfusion. And we have to think of a urine leak as it is a clinical emergency. And to support the diagnosis, we get an ascites creatinine. And here it is significantly elevated and it's higher than the serum creatinine, which supports the diagnosis of a urinary ascites. And the reason this happens is because when blood is being filtered through the glomerulus, water and waste products, including creatinine, remain concentrated into urine. And so this urine, when it leaks into the abdominal cavity, it becomes concentrated in the peritoneum. So our ascites creatinine becomes significantly elevated and higher than serum creatinine. And this patient on cystography showed a urinary leak, as you can see here by the arrows in the peritoneum. And so he was diagnosed with a bladder rupture. And so here are some of my take-home points. So SAG is crucial for determining the underlying etiology of ascites. A low SAG of less than 1.1 indicates capillary permeability and inflammation. So this is an exudative process or a non-portal hypertension process. An elevated SAG of more than 1.1 indicates a transidative process or a portal hypertension. However, we can have ascites with an elevated SAG due to non-portal hypertension. So things like peritoneal dialysis, chyle, or urine in the peritoneum. And when we have an AKI in the context of acute ascites, this suggests fluid leakage into the peritoneum, impairing renal perfusion. So we want to rule out urinary ascites by getting an ascites creatinine. If it's higher than the serum creatinine, that indicates a urinary ascites. And that is the case. Very interesting. So thank you all for listening. And these are my references. If you have any questions, please let me know.
Amazing job, Masa. Thank you so much. I really liked your presentation and the way you simplified the SAC because I always get confused with that. So thank you very much. And now with our second case presenter, who is Bayan. So Bayan, please introduce yourself and start your presentation.
So, hello everyone. I'm Bayan Zerbi. I am a final year medical student from Syria, and I will be talking to you about the case that was presented on the 12th of November. So, the case was presented by Dr. Neha, and the case discussant was Dr. Chika Jain. And we're going to be discussing today hypercalcemia of malignancy. So this was a 63-year-old man who was referred to the ER by his primary care provider for hypercalcemia that was incidentally discovered on routine labs. So his calcium level was found to be 14, and when they got a history and conducted the exam in the ER, he was found to have poor appetite, a 10-pound weight loss, constipation, and poor memory recall, and he was ultimately diagnosed with adenocarcinoma of pancreatic biliary origin. So to start, I'm going to recap a bit by discussing what are the signs and symptoms of hypercalcemia before we move on to discuss the etiologies and other factors that are associated with hypercalcemia of malignancy. So to start, we have neuropsychiatric symptoms, which include anxiety, depression, confusion, lethargy, and even comas in very high levels of calcium. The patient might also present with muscle weakness and non-specific pains. They might present with GI symptoms such as loss of appetite, nausea, vomiting, abdominal pains, and constipation. They may present with renal symptoms such as polyuria because we know that calcium draws out the water into the urine. They may be dehydrated because of increased water loss through the kidney, and they may have symptoms of nephrolithiasis such as flank pain, such as minor hematuria, and other symptoms of having kidney stones. And finally, and what we worry about most is cardiac symptoms, which are usually palpitations secondary to arrhythmias that occur with the disturbance in the calcium levels. And you have to keep in mind that these symptoms may seem that they're arranged from like the least severe to the most severe, especially in the case of neuropsychiatric symptoms, and they are directly proportional to the level of calcium. So the higher the level of calcium, the more severe the symptoms are. But you also need to keep in mind that the levels of calcium are going to be not the only contributing factor, but also the speed with which the level of calcium rises. So the more quickly the level of calcium rises, the more severe the symptoms will be. And the slower the level of calcium rises, the milder the symptoms will be. And this is just because the body had adequate time to compensate for the symptoms of hypercalcemia. So I want you to answer the following question, and that is, when do you really consider hyperglycemia of malignancy? When would you say that maybe this patient has hypercalcemia of malignancy? Right, so yeah, so you would really take a history and assess for risk factors in order to determine if this patient may have hypercalcemia because of a malignancy. So you think about first the risk factors of malignancies. So smoking is a huge risk factor for many types of malignancies, including, for example, lung cancer, which we know if it's squamous lung cancer can sometimes cause hypercalcemia by secreting PTRP. And also, drinking alcohol is a significant risk factor for many different kinds of cancer. And sometimes the patient will report family history of multiple endocrine pathologies. So, if you think about it, they might say, oh, this person in my family had a pituitary tumor, that person in my family had their parathyroids removed, and all of this should make you really think about multiple endocrine neoplasias or MENS syndromes, because the patient might not really be aware of what a MENS syndrome is, but you need to connect the dots and decide maybe they have a family history and we should be thinking about this. The age of the patient is also important. So we know that malignancies are more common in older patients. And you also need to think about like constitutional symptoms, especially weight loss, anorexia, loss of appetite. All of these symptoms might clue you in that there is a malignancy at play. And finally, what we mentioned earlier is if you have very high levels of serum calcium, but the patient has only mild symptoms, then you really need to put malignancy at the top of your differential. And that is because, as we said, the body has adequate time to compensate with a malignancy because it just doesn't appear overnight, right? So it takes weeks, months, and years for this malignancy, in some cases, to grow and secrete more and more levels of maybe PTRAP or other compounds that may increase the serum calcium. Now I want you to think, what are the possible etiologies of hypercalcemia? So what are the mechanisms of hypercalcemia that you know can be attributed to malignancies? I think we mentioned one when we mentioned the risk factors, but I'd love to see what more you guys have in mind. Yeah, so Lara is mentioning metastases, which is a very good thought. And Valley is mentioning parathyroid related peptide, which is also a very good thought. So the etiologies of hypercalcemia of malignancy, we can start with humoral hypercalcemia of malignancy, which is basically mediated by parathyroid related peptide, which Valley mentioned. And this is a peptide that is very similar in configuration to the naturally occurring parathyroid hormone that we have in our body. So it acts on the very same receptors that parathyroid hormone acts upon, and it leads to the increase in level of calcium. And then a good example of this that we might see frequently is squamous cell carcinoma of the lung. And here you tie in the risk factors. So someone who has a smoking history, they're coming in with a maybe a cough, maybe shortness of breath, maybe hemoptysis, and they are there you find the calcium level to be, say, 16. You really need to think and connect the dots here. Another example is what Lara had mentioned, which is osteolytic metastases, and these are metastases or malignancies that can spread to the bone, and they lead to the breakdown of the bone, and they lead to an increase in level of calcium. And a good example of this might be multiple myeloma or like breast cancer. Other examples of hypercalcemia of malignancy are ectopic 1-alpha hydroxylase or calcitriol activity. So if we remember the vitamin D metabolism, the vitamin D which we ingest or which is formed in the skin needs to be activated into its active form, which is called 1,25 vitamin D. And so the final step in the activation is activation by 1-alpha hydroxylase. So if we have a tumor that is able to produce 1-alpha hydroxylase, and that will be able to activate vitamin D, and that will lead to an increase in the level of calcium. And some tumors secrete activated vitamin D directly, so that is called calcitriol, and those may lead to hypercalcemia of malignancy. So an example of this is lymphomas and very rarely ovarian germ cell tumors, and this is a very rare process. And what surprised me the most while preparing this presentation was that parathyroid producing tumors are actually the least common out of all the 4 causes that we have discussed. So parathyroid tumors like parathyroid adenomas or carcinomas, and rarely, as in the case of our patients, GI malignancies can secrete calcium. You might think that this is a more common cause, but it actually is the least common cause. And if you think about it from a point of view of the incidence of the various malignancies, lung cancer is much, much more common. So it makes sense kind of that the mechanism that it facilitates would be more common. All right. On the CP Solver's website, you will find this very good schema that discusses the elevation of calcium, not in the context of malignancy only, but in general. And you can see that certain types of malignancies will contribute to the increase in calcium through a pathway that is not PTH mediated. Finally, the most important part for us to discuss today is the treatment of patients who are hypercalcemic and have a malignancy. So these patients, number one, they are volume depleted. That is because they have polyuria, they have decreased oral intake, they may be vomiting, they may be nauseous. So the first thing that you need to do is give them IV fluids. Start them on IV fluids. This is going to improve their volume status, and by virtue of diluting their serum, it is going to lead to a decrease in serum calcium levels. And then to address the issue and reduce the calcium levels, you can give calcitonin, which is the hormone that we naturally have in our body that reduces the calcium level. So you give it externally, and then you can give bisphosphonates, which are compounds that inhibit the bone resorption, and this is especially effective in the case of osteolytic malignancies, which will break down, um, sorry, which will break down the bone. And finally, and most importantly, to treat the root cause of the issue, which is treat the underlying malignancy. Now, this is going to take time. You're going to need to biopsy the lesion. You're going to need to stage it and determine what is the best course of action. But until then, you can give the patient IV fluids, calcitonin, bisphosphonates. Some references will even say you can give loop diuretics because of their they have an effect of it increasing calcium intake, especially in the case of patients who are volume overloaded. And in some severe cases, especially if the patient is going into, for example, renal failure, you might need to do dialysis. But in general, these are our mainstay of treatments. These are my references, and thank you all. I'd be happy to take any questions if there are any questions.
Outstanding presentation, Bayan. Thank you very much for sharing these pearls with us. So now moving to our last presenter, Julia. Can you please introduce yourself and share your screen?
Sure, thank you so much. So, good morning, good afternoon, everybody. My name is Julia. I'm a medical graduate from Germany, and I would love to welcome you to the third part of our teaching point recap session today. And just a brief introductory word. So I really love this format so much because we get so much input each and every day, and it really allows us to revise and reframe what we learned throughout the weeks. So I'm very grateful for this opportunity today. A huge thanks goes to the case discussions, Rabi and Anmol, who discussed the case just brilliantly, I think, last Thursday. And it was about joint pain. And I thought the prevalence of joint pain is quite high, especially in the emergency department. And I tried to organize the thoughts of the two case discussions last Thursday a little bit, and I hope you're going to enjoy that. So we had a 60-year-old male patient who presented.
Sorry for interrupting, but we can't see your screen. We only
You
can see,
can't.
yeah, the handlebar from above, but we can't really see your screen.
Oh, let me. Does it work now?
Yeah, good.
Oh, sorry, guys. So yeah, we started off with a 60-year-old male who presented with 5 days of right-sided knee pain. And I want you now to imagine you're a resident in the emergency department and the triage room is packed and you're wondering, like, can I send this guy home? There's so many other patients to take care of, or is there any treatment necessary right now? Like, how urgent is this issue? What do you want to know, and how would you approach this patient? You're free to put down your thoughts in the chat if you like. I tried to answer this question as well, and I kind of like the analogy to our, say, 4+2+2 mnemonic we use in chest pain. So we really want to rule out any emergency causes of joint pain right away. And the one emergency cause we really want to rule out is septic arthritis. The reason why is because the mortality is quite high despite antibiotic use, so in between 7 to 15% mortality. And also it is associated with a rapid destruction of the cartilage of the joint. So now, what would you do next? Like, what clues can you collect from history, exams, or what diagnostic tests would you do next? I mean, you remember that history is key and clinical exam is key, right? So you examine the patient, ask him a couple of questions, and he says that he was treated for a gout flare 3 days ago, has now worsening symptoms and a reduced range of motion. And also he reports subjective fever and chills and was admitted for 4 months or presented with a wrist abscess 4 months ago. On exam, you see the knee, and it is red and tender right around the knee. The vitals are normal. So how does that help us? You also remember that like the classical presentation of septic arthritis include a swollen joint, pain, and limited range of motion. And you also remember like the large joints are mainly affected, especially the knee and over 50%, but also hip, shoulder, and elbow. But as your gut feeling probably says you, these findings are not very sensitive or specific. So literature tells you that only 85% present with pain, 78 with swelling, and around 57 with fever. So that says, that being said, it means that around half of the patients with septic arthritis don't even present with fever. And if you look with on sweats and rigors, it's even worse. And also there's so many other diseases that are associated with these symptoms. Like here's a list I found, which I thought was very conclusive. So very prevalent would be gout, also rheumatoid arthritis. So how do you kind of get a little bit more sense of what's going on here? You draw some labs. The white blood cells count is normal, but striking is an elevated CRP and ESR. Now you're wondering, like, how does that these lab findings change our pretest probability for septic arthritis? So the white blood cell count is not elevated, but that's not untypical. The ESR is elevated, but the likelihood ratio is only 1.3, and quite similar for an elevation of CRP. So that doesn't really help us that much either. So that's something we learned from Robbie last week, is like a practical approach to really know what patient is worth to tapping or not. So you can ask yourself 3 questions. First, how many joints are involved? So in polyarticular disease, it's often, or arthritis, it's always a systemic disease, meaning there is like a disease scattered around the whole body. So the tap is often not very conclusive. So when you know it's a monoarticular disease, you should also know the pitfalls. So first, any systemic disease can obviously present first as a monoarticular disease and develop in polyarticular. And also, septic arthritis can be polyarticular in 20% of patients, but these are mostly immunosuppressed. The second question you ask is the problem extra-articular or intra-articular? So there are two exam findings that can help you with that. The two I's, instability and inflammation. With instability, we're meaning that the joint is more like laxive than expected, and that would be a hint to towards extra-articular problem. And the inflammation can help us too. For example, if it's like a localized issue and swelling and warmth, it's more a hint toward extra-articular. Whereas if you have a diffuse round swelling around the joints, it does point toward an intra-articular problem. Lastly, a very prevalent osteoarthropathy you often have when there are disproportionate swelling with no signs of inflammation. That obviously does not need empiric antibiotic treatment. So with your exam, you were able to kind of rule out the extra-articular courses, but there's still so many intra-articular ones. So should we actually tap and treat so many patients? And to answer this question, you really have to remind you again that even though the prevalence of septic arthritis in acute, painful, and swollen joints is only about 8 to 27%, but the mortality and morbidity is so high that we should tap anybody that follows our algorithm. So having signs of inflammation and one joint involved. I want you now to think about the synovial fluid. What information would you like to take out of the fluid? What helps you? So data shows that the most interesting value is the white blood cell count. So over 50,000, that would be our cutoff point. The likelihood ratio is 7.7 that we are dealing with a septic arthritis. And that is something Robbie showed us last week again as well, is that even though the prevalence of crystal disease is much, much higher than septic arthritis, around 50,000 white blood cells, it's an inflection point where crystalline disease gets a little bit less and likely, and septic arthritis still rising. The other important information is the PMN count. So any number above 90% is associated with a high likely or with a likelihood ratio of 3.4. Other information like protein, LDH, and low glucose doesn't really help us that much. Even though LDH has a high sensitivity, it's not very specific. There are some studies going on about TNF-alpha that has a high sensitivity and specificity, but it's not established yet. Another thing I would love to revise was the color of the synovial fluid. So with yellow fluid, we always think about inflammation or septic arthritis, but it can also be associated with non-inflammatory causes, so we shouldn't be fooled. Now, turning back to our patient, so the case continues. We are doing or performing an X-ray and see some osteoarthritis is seen, and the fluid analysis shows an elevated white blood cell count, 90% polymorph nuclear cells, no crystals, and the gram stem is negative. Our patient is empirically treated as explained a minute ago. So that is kind of our approach if we analyze synovial fluid. We should first think about the gram stain, but keep in mind that it's often negative, only a sensitivity of 29 to 50%, and the culture has a sensitivity of 80% only. Second, we should have a look at crystals. If they're intracellular, we know that crystals are at play at the moment, but crystals in general just say that there was some crystalline disease at any point. Third, we should have a look at the white blood cell count and PMN, and lastly, think about risk factors. So for the risk factors, we need to understand the pathophysiology of septic arthritis. What's quite interesting to know is that that synovial tissue has no limiting basement membrane, so organism can enter it quite easily. So mostly septic arthritis is due to endogenous spread from hematogenous spread, so bacteremia, continuous spread, or also associated with a high vulnerability, so either localized in rheumatoid arthritis or generalized in HIV, for example. 30% are exogenous, so gonococcus or Borrelia being the leading causes. Generally, we should think about septic arthritis in two peaks, so in childhood and people older than 55 years. That's just one thing I wanted to emphasize is that in prosthetic and skin infections, you have a high likelihood, for example, that you have septic arthritis, and a high specificity, but it's only a clue because it's not very sensitive. Same accounts for rheumatoid arthritis. So you always have to keep the whole picture in mind. According to the slides before, these are all the history questions that are interesting. So sexual history, tick bites, trauma, family, rheumatologic disease, gout, endocarditis. So keeping track of the history is always very important. In regards to the history, there is one exogenous cause that is always interesting to keep in mind, especially in women, is the arthritis in gonorrhea. And what is important here is that it's less destructive than in non-gonococcal disease. And you should think about it with migratory polyarthritis, vascular pustular skin lesions, and tenosynovitis. Why it is important to keep in mind is because the culture is often negative and the gram stain as well. So there's a specific gonococcal medium you need to culture this bug. And you should perform a NAT test. So in our patient, concentrating on the history, he had asthma, gout, bilateral osteoarthritis, and a polysubstance use disorder that makes him vulnerable to other infections. He has no history of tick bites, and he's sexually inactive. Now, when we think about the empiric treatment, we should really have to keep in mind what bugs are the most prevalent to cause septic arthritis. So these are Staphylococcus and in 56% Streptococcus and rarely in 15% gram-negatives. And that leads us to the treatment. So first, our patient needs a joint drainage. And he received also empiric treatment with vancomycin and ceftriaxone. If we have the result from the gram stain, we can narrow down our antibiotic treatment. So with positive cocci, we think about MRSA, and in negative bacilli, we need ceftriaxone. And only if we have risk for Pseudomonas, we would add ceftazidime and an aminoglycoside. The culture after days revealed that our patient had Cutibacterium acneseptic arthritis. So the treatment was quite right, and hopefully his joint was rescued from further destruction. Now I'm coming to the take-home points, and just wanted to sum up that patients with joint pain have to be taken seriously, and septic arthritis has to be ruled out. And it may be very difficult to diagnose the patient because of non-specific signs and symptoms. Empiric treatment has to be established as soon as possible because of its high morbidity and mortality. And how do we approach that? So first, establish how many joints are involved. Are there any signs of inflammation around the joints? What is the white blood cell count, and are there any risk factors? Keep in mind that the gram stain and culture are often negative, and crystals positive do not rule out septic arthritis, and they depend on the examiner, and they are going to be positive the whole lifespan. Lastly, gonococcal arthritis need a special culture, is less morbid, and you can diagnose it with a NAT test. If you want to revise this very complex issue, problem of joint pain, we have a beautiful schema on our website that I would recommend you all to have a look at. So thank you so much, and these are my references, and if you have any questions, I'm happy to answer them.
Amazing presentation, Julia. Thank you very much for simplifying the topic and making it very practical. I think I'm ready to approach any patient with joint pain now. So that's a wrap for today. Thank you all for joining us. Thank you, Masa, Bayan, and Julia for your presentations, and hope to see you all next time. Thank you.